Hi, everybody. Welcome to the next week of our course. This week, we're going to be talking about dilemmas of medical technology. It's important, of course, in dissecting this topic that we understand what medical technology is. So medical technology is any technology that's used in medical contexts to diagnose or treat different medical conditions or statuses. A few examples would be software used in healthcare facilities, surgical machinery, specimen testing technologies such as urinalysis machines, respirators, EKGs, and medications, so on and so forth. Medical technology also includes tech or assistive devices that are used by a lot of people with disabilities, such as devices like mobility aids, glasses, contact lenses, hearing aids, stoma bags, other types of assistive devices or tech that can improve a person's quality of life or functioning. Medical technology has brought a lot of amazing advancements and improvements for quality of life for people all around the globe. But of course, this week we will be talking about dilemmas of medical technology, some of the ethical dilemmas, as well as just logistical and financial dilemmas. Here on this list, we've got first cost barriers. Of course, a lot of medical tech is not easily affordable. It's not accessible in every region. Not every hospital can have the most high-tech, up-to-date technology, and not every person can access every type of technology that might benefit them. We also can see technology malfunctions in certain cases with different techs. Um, we might see surgical machines malfunction. That doesn't happen often, but the possibility of technological malfunction is never 0%. And so that's something that we want to be looking at and concerned with in researching medical technology. We also can see, of course, unexpected negative impacts of the use of different medical technologies, particularly when we look at medication as a technology. A lot of medications are really well studied and tested, but of course, not every person responds the same way to every medication, and we can see abuse of medications or negative side effects for some individuals. We might also see an over-reliance on technology as kind of the end-all be-all solution to treating medical problems or assisting with different kinds of medical states or statuses. Finally, we also see the psychological impact of diagnosis as something that could be a possible consequence of diagnostic technologies being used. That's not to say that diagnosis itself is a bad thing, but dealing with a difficult diagnosis can be very, very challenging. If a person is diagnosed with, say, cancer or a terminal illness of some kind, that technology makes that diagnosis possible, but the psychological impact of the diagnosis is something that we want to, as sociologists, be looking at. Life support technology, in particular, also complicates our understandings of life and death. It makes it kind of a little bit of a gray area in some cases, whether a person is alive or not, with certain types of life support technology. And finally, we have kind of a difficult topic here when we come to eugenics and the goal of eradicating disability or different kinds of health concerns and diseases through the use of medical technology. That is something that we see a lot in sci-fi movies, but it's also something that we kind of see in our day-to-day reality, that a lot of people believe that with technology, we will be able to completely get rid of disability and illness, and that is simply not the case. That is not reality. Disability will always exist as part of the human condition. And we'll talk a little bit about the consequences and the impact of these kinds of beliefs and technology use on the disabled community. Looking at one specific example of medical technology here, let's talk about prenatal genetic testing. So what is prenatal genetic testing? This is testing that is done on the DNA or sometimes the amniotic fluid of a fetus prior to birth. This genetic testing is done to look at the genes of that fetus and see if there are any potential differences in those genes compared to what might be more typical. So a lot of people use it to try to detect different kinds of so-called abnormalities, looking for specifically chromosomal differences. A lot of the time, people might do this type of testing to look for conditions like Down syndrome. And this is very common. A lot of individuals will go through prenatal genetic testing. A lot of people are very encouraged by their doctors to do this testing. But what we want to look at as disability sociologists and medical sociologists is what happens when disabilities are found. What happens if prenatal genetic testing shows that there is a high likelihood that a baby will be born with Down syndrome, for example? We want to acknowledge in this case that the results of this testing can be unreliable. They are not always 100% definitive with every kind of condition. We do understand human genetics a lot better today than we used to in the past. For about the last decade or so, we've had a very, very good grasp on a lot of genetic links between diseases and genes, but it's not foolproof. The results are not 100% reliable, and sometimes they're kind of presented as though they are. It's also really important that we acknowledge that, in certain cases with certain diseases that may or may not be present, doctors may recommend selective termination or abortion for disabled fetuses. Um, in these cases, we want to just be thinking about, what are the ethics of the situation? Why are we using this technology? What are the goals? What are the impacts of the information that this technology gives us? And what are the potential outcomes or consequences of acting on or not acting on that information? I'm not here to tell anybody what to think or to change your mind about anything, but we will deconstruct some discussion of abortion and termination of pregnancies in this class, especially during this topic. So please try to be open-minded as we cover this topic here. Particularly in looking at disability and with the long history of eugenics, it's very important that we have this cultural context in mind when discussing this topic. So we want to be thinking about, what are the potential limits here? What are people thinking about when they make these kinds of decisions? Are people, making decisions for their own personal reasons? Are they influenced by culture, by religion, by their family, their partner, their doctor? What are the boundaries that people are kind of making those decisions based on? Are there certain disabilities that are seen as too severe? And in that case, an individual will feel maybe this baby should not be born. Um, Maybe selective termination is the right decision in that case. What are the boundaries there? Who gets to make those kinds of decisions, right? And of course, this is a big topic in the media. This is a big topic in politics right now. Um, but putting abortion to the side for a second, if we're just looking at the disabled community, a lot of disabled people feel that prenatal genetic testing is a form of eugenics because it can lead to the selective termination of disabled fetuses. And in that case, yes, we can consider this a form of eugenics. But at the same time, we have to consider the context of the pregnant individuals, the families and the culture that they are a part of, their personal situations, and the quality of life of the potential baby that fetus could become. Um, and the reality that we don't have very good social support for disabled individuals, disabled children in our society. So this is a really complicated topic. There's a lot of gray area and a lot of emotion wrapped up in this. And I think it's a really fascinating look into how there can be a lot of dilemmas around different kinds of medical technologies. Diving a little bit more into some of the complicated dilemmas and ethical considerations of prenatal genetic testing. This is something that medical sociologists are really, really interested in. And we want to look at all of the different sides of this issue. So first and foremost, parental autonomy is really important for both the pregnant individual and any other person or partner or significant other that may be in their life, helping with that decision-making process, dealing with what could be a very difficult situation in a lot of contexts. So, if someone is pregnant and they find out that their fetus is very likely to have a very life-altering disability, that is a very challenging situation for a lot of reasons. And so, what that person decides to do is really up to them, up to their social circle, their network, and potentially a conversation between them and their doctor, because that is a very difficult decision and a very difficult situation to be in. How does a person make that decision? Really, this is something that doesn't have a very clear answer. There is a lot of different perspectives on this topic, so it could be very complicated. We hear a lot of arguments about, should somebody have children at all if they can't parent a disabled child? Coming from that perspective of, 1 in 5 people are disabled, and so there's a pretty high likelihood that a person who has children will have a disabled child. And if that's something that is, um, very maybe off-putting to that person or something that they feel that they just could not handle, some people would argue, okay, maybe that individual should not have children, period. Other people will say, well, maybe there's more nuance to this topic. Maybe it kind of depends. And we'll see that, in sociology, a lot of the time the answer is it depends or it's a gray area. We also see ableist assumptions that disabled lives are tragic and that you cannot have a good quality of life as a disabled person. This is absolutely not true, but we have this belief floating around through our society, and a lot of people, take that belief with them through life and think if I have a disabled child, that they will have a bad life. And that is absolutely a possibility, right? There's no guarantee that any person will have a good life or a good quality of life, disabilities or not. And so people are really weighing these kinds of topics in this kind of decision-making process. There is, of course, also a lack of support for parents of disabled children and for disabled people of all ages in our society. We just simply do not have good support or good resources for this community. That is absolutely something that needs to be fixed. There are people and nonprofits who are working towards that goal of having better support, but as it stands today, it's just not a very robust support system. And so that is something that people are considering in this difficult situation with that use of prenatal genetic testing and that possibility of disability. A lot of people are thinking, okay, this is going to be very difficult for a lot of reasons because we just simply do not have good support in our society for families with disabled family members. Of course, we are, working to build up better healthcare, better community services, more resources for these communities, but it is not an overnight process. So all of these things lead to a very messy ethical situation with, kind of a tinge of eugenics concern, um, a lot of debate about abortion in this kind of case as well. There's a lot of questions that prenatal genetic testing opens up. And so again, it's every individual's choice if they find themselves in this kind of situation. There is no right answer. There is no end all be all black and white. This is the way this should be kind of solution for this sort of thing. It's just something for us to be thinking about in a class like this because there are a lot of potential dilemmas introduced by this particular technology. I want to call attention here for a moment to a creator who I think you all would really benefit from engaging with her content. Her name is Nina Tame. She is an activist and content creator who has a disability called spina bifida. She also has a child who also has spina bifida, her son, and she shares a lot about these topics. So she talks a lot about eugenics and disability history. She talks about her own experiences as a disabled person who is a parent and a parent of disabled children. And she has some very interesting perspectives that I think everybody could benefit from understanding. So I encourage you to read this quote here and to check her out on TikTok, Facebook, Instagram, wherever is your social media of choice. Another medical technology that introduced a lot of dilemmas and did a lot of harm was a drug called thalidomide. This is something that was used as an anti-nausea medication by pregnant people in like the 1950s, 1960s, kind of the mid 20th century. And at the time, it had not been tested on pregnant individuals. It had only been tested on non-pregnant people, mostly on cisgender men. And so the potential for congenital abnormalities that occurred was just really not known until after this was something that was being used very, very at very high rates. And so a lot of people were using thalidomide, which led to the development of congenital disorders for about 10 to 20,000 babies during that period of time. So a really large portion of the population. And a lot of those babies did not survive, but a lot of them did grow up to become adults. Um, and this is just a really great example of how medical technology can be very, very useful, but can also be very, very harmful without the right research and focus into all of the best practices, the best uses of that technology, especially for medications, because this is actually a drug that is very safe in certain contexts. It's still used today to treat different kinds of cancers, certain skin conditions, and also leprosy. So this is something that can be used in certain contexts. It could be a very useful medical technology, but it can also be very harmful or dangerous in other kinds of contexts. And that is the case for a lot of medications and a lot of technologies. All right, so I've used this term eugenics several times throughout the class, but we haven't really done a deep dive into this topic yet. Many of us are probably familiar with the term eugenics or genocide. A lot of us have heard these words in our day-to-day lives, but in the context of social health and illness, what is eugenics? Um, one definition is that eugenics is the practice of seeking to improve, in air quotes, the human race by decreasing the proportion of humans with so-called undesirable traits and increasing the proportion of those with so-called desirable traits. A lot of the time, eugenics is carried out through things like genetic testing, abortion, often forced abortion, genocide, forced sterilization, forced birth, and so on. Of course, all of these being really, really horrible things that nobody should ever have to go through, but we do have a long history of these kinds of practices in the United States and worldwide. Across the board, eugenics beliefs and ideologies reflect a lot of racist, white supremacist, queerphobic, transphobic, homophobic, sexist, ableist, and classist ideologies. All of those isms and phobias that we talk about in sociology, these really come to a head with something like eugenics, which can lead very directly and very quickly and easily into things like genocide and other very, very violent types of discrimination. There are a few different kinds of definitions that we can use in discussing different forms of eugenics. There are political eugenics as well as biological eugenics. Political eugenics being liberal eugenics. In this case, this is where individuals independently or autonomously choose genetic characteristics of future babies. So if you've heard about designer babies or people using genetic editing to create embryos with so-called desirable traits, that could be an example of liberal political eugenics. We also see authoritarian eugenics, and this is where the state, so the country or the government, that is who decides which genetics are considered valuable and who should or should not be born. One example of authoritarian eugenics that many people are familiar with would be what was happening in Nazi Germany during the 1930s and 40s. When we come to biological eugenics, we have both positive and negative eugenics. And this is not a moral valuation, positive or negative. This is kind of like math in this case. So positive would be essentially adding, promoting the births of babies with so-called desirable traits. So increasing the amount of people in the population who have those so-called desirable traits. Negative eugenics, on the contrary, being this decrease or subtraction, so avoiding or preventing the birth of babies with so-called undesirable traits, decreasing the amount of people in the population who have these so-called undesirable traits. We see a lot of different traits being seen as desirable or undesirable. We're going to talk a lot about disability in this class, but we also see a lot of these kinds of ideologies affecting people of different races, gender identities, socioeconomic statuses, and a variety of other kinds of identities. Eugenics is not limited to just kind of this health-based or body-based focus or a disability kind of focus. This bleeds into a lot of different areas. So eugenics and modern technology do unfortunately have some clashes. We have already talked about this a little bit when exploring prenatal genetic testing. But medical technology and the use of it, or our just really intense faith in this technology, can lead us to believe that we can prevent illnesses and disabilities entirely, or that we could eradicate disability, make sure that there is no disability left in the human population. And this is actually impossible. There is never going to be a time on Earth where disability does not exist. Disabilities come from all kinds of different illnesses, injuries, life experiences, and many people are born with disabilities. In that case, that would be people who are born with disabilities, contrary to people with acquired disabilities. But in this case, let's think about, why could disability be a good or a positive thing for a person? We don't often hear that kind of spin on disability. A lot of our discussions are very medical model, are very pathologizing, and we don't see a lot of positive representation of disability or disabled lives. But there are a lot of reasons why disability is not a bad thing. It's not a traumatic, scary, shameful, or terrifying thing to be avoided. That's not to say that becoming disabled is not difficult or that having a disability is always all sunshine and rainbows. If you recall our discussion of the patient experience a few weeks ago, disability can be very difficult for a lot of reasons. One of those big reasons is ableism, more so than the actual lived experience of having a disabled body. But there are a lot of things about disability that are very positive, such as increased empathy, more grace for oneself, increasing skills with self advocacy, building community with other disabled individuals, having a more open minded approach to people with other different identities, a deeper understanding of privilege and oppression, and just a variety of other things that we'll actually explore more in the following slides and in a few weeks in some other lectures as well. Um, Moving on to this next question here, why the goal of ending disability is problematic. Um, there are a lot of reasons, but of course, the goal of ending disability really devalues the disabled community and disabled people. So if we have this goal of let's get rid of disabilities, what that is saying is that people with disabilities are worth less, right? That we do not respect them or that their lives are seen as, not as good or their quality of life is looked down on or devalued. And that is very problematic. A lot of disabled people have really amazing lives, just as amazing or better than people without disabilities. And so we really can't have this black and white understanding of disability versus non-disability. Um, and we really can't be valuing people's lives based off of that kind of identity factor because it's a very, very complicated thing. It's a very complicated part of a person's experience and identity. Looking at a few more examples of modern eugenics, we can look at some triaging practices during the COVID-19 pandemic. Of course, this was very, very recent for all of us. This is something that we also could call medical rationing. So during COVID, during the pandemic, especially early on, like kind of the spring into early summer of 2020, triage practices that were taking place in ICUs and in hospitals were a really interesting case, a really interesting look into a potential example of modern eugenics against disabled individuals. So when there were really limited ICU beds in hospitals across the country and across the world, the people who were receiving treatment were most often going to be younger individuals, people who were visibly non-disabled, people who could advocate for themselves in one way or another. And so, on the contrary, individuals who were visibly disabled, potentially lower socioeconomic status, potentially older individuals, were kind of being discriminated against in this kind of case, being denied beds, denied care, or sent to seek care in other contexts, at other institutions, and so on. Of course, these decisions are really difficult. Triaging in a medical context is not easy. If there are limited supplies and more patients than there are beds, or more patients than there are respirators, some difficult decisions are going to have to be made. Of course, one great solution to this would be to just have a stockpile of available resources so that in this kind of instance, there is nobody who is lacking a bed or who is lacking care. But realistically, that is not always going to happen, especially in rural areas. So when those decisions are being made, when we're deciding as medical practitioners in a triage situation who receives care and who does not, the decisions can be based on things like perceived quality of life, the belief that people with certain types of bodies, certain types of abilities, or certain socioeconomic statuses and ages are likely to have more or less life left ahead of them, higher or lower quality life left ahead of them. And so a lot of medical practitioners are trying to preserve the highest number of years with high quality of life for as many patients as possible. But in this case, of course, we are seeing this assumption that disabled people are not going to have high quality of life. Either they already don't or they won't in the future. And so that denial of care is really, really tricky because it can just be based on those assumptions, right? That does not really necessarily reflect the reality for a lot of disabled people. And so During the triaging during COVID-19, during 2020 and 2021 in particular, a lot of disabled people handled this in ways that are really honestly heartbreaking. A lot of people were doing things, discussing, in online forums about how to handle these things, saying stuff like, keep pictures of your family or your children in your wallet. If you show up to the emergency room, make sure you get dressed and you look nice before you go so that they take you seriously, so that they respect you. Try to look like you have more money than you do so that they will think that you can pay for your treatment. All of these kinds of suggestions to really humanize yourself as a disabled person, especially a visibly disabled person, to go into that ICU and seek care and have a higher likelihood of being able to receive that care, and not be turned away. Exploring another example now of eugenics and oppression of a disabled community, let's look a little bit at the deaf community, specifically deaf culture and history. First and foremost, it's important that we understand the difference between capital D deaf and lowercase d deaf. Capital D deaf being people who are culturally deaf. So this will often mean individuals who are born deaf into a family with other deaf family members. Often these individuals will grow up using ASL or American Sign Language throughout their life, and they are participating in deaf culture on a regular basis, or lifelong. The lowercase d, deaf, more so refers to the diagnosis of hearing loss making a person deaf rather than being culturally deaf. And so a lot of individuals who are deaf, especially culturally deaf individuals, might debate about whether deafness is a disability or just an identity or cultural status. And there are very mixed ideas about that topic. But one way or another, since our society does tend to treat deaf individuals as disabled, or barriers in our society make life more difficult for deaf individuals, it's important that we include this culture and this community in this lecture. There's a long history of oppression and eugenics and just really, really horrible treatment of the deaf community in the United States and worldwide. In the United States in particular, if we kind of highlight on the United States here, we have a long history of people being denied access to their culture, being told they cannot use sign language, especially students in schools. There is a process called mainstreaming, which is where a deaf student is put into a hearing school. Through especially the Victorian era, this mainstreaming also involved the presence of something called oralism. Um, Oralism was a perspective or approach where students were expected to communicate using their voice rather than with signed language. And in that case, basically people were being stripped of their culture, denied participation of their culture, or participating in their culture, and really just the oppression and the subversion of the individuals in this community was really intense, very ableist, and extremely problematic and harmful. We have seen this improve over time. There were some really barbaric practices taking place during that period, especially in the late 1800s, where deaf students were being having their hands bound so that they could not sign in classes, being forced to keep their hands flat on their desk throughout the entire day so they could only use their voice to communicate and other things like that. There's a lot more information about deaf history and deaf culture that I would love to get into, but for the sake of time, this is just a little bit of a spotlight, a little bit of a tiny introduction to this topic. And we'll talk a little bit more about how some medical technology and this community interact in a way that gives us more dilemmas that we can analyze and discuss for this week's content. So one main topic that I want to discuss this week when we're looking at medical technology is the cochlear debate amongst the deaf community. So cochlear implants, these are a type of hearing aid that work via an implant in a person's head. A lot of deaf individuals might choose to get a cochlear implant. A lot of people might have had no say in it, especially if they have hearing parents. A deaf individual might be born and undergo the surgery before they are old enough to understand really the implications of it. So this is something that we see pretty often. A lot of deaf people, though, also choose not to get a cochlear implant or not to use hearing aids. Um, Before I give some more information about this, I want you all to think for a moment, why might a person choose not to get a cochlear implant or not to use hearing aids? There are, of course, a lot of personal reasons for this, but if we look again at that capital D deaf community, a lot of people being deaf is part of their identity. They don't see it as a problem, they don't see it as a pathology, they see it as part of who they are, part of their culture, and not a problem, not something that needs medical fixing or medical intervention. And so the use of this medical technology of either cochlear implants or hearing aids in general, specifically cochlear implants because they do involve surgery, a lot of people are very against it because they feel that it does not align with their values and their beliefs that being deaf is a part of their culture and it's a beautiful part of who they are, and it's not something that needs fixing. However, there is a lot of pressure in our society, in our culture, for deaf people to get hearing aids, whether it's a cochlear implant or otherwise. And it's important that we think about, why is that? Why does that pressure exist? And it really comes down to, subversion of cultural norms and social norms. We have this expectation, which we can say is rather ableist in our society, that every person will be able to speak, to communicate, and listen and hear other people in their environment. And that is simply not reality. We have deaf and hard of hearing people all over the place in the United States and worldwide. I myself am completely deaf in one ear. I am about 50% deaf, if we want to say that. I'm hard of hearing, is what I usually say. Um, but I am someone who is not culturally deaf. I would be that lowercase d deaf in my right ear because I did not grow up in a family that used sign language. I had hearing loss occur later in life when I was a teenager. And so there's some nuance to those experiences with that being an acquired disability in my case. And I personally do not use any medical technology to correct my hearing. I have ways to kind of get around the difficulties that I do run into. And I think that there is a lot of beauty in the deaf community and the deaf culture that is rather disrespected by the ableism directed towards the community, particularly this pressure for everyone to use hearing aids or to get cochlear implants, because that is not everybody's preference, and it's only seen as necessary because of that medical model emphasis on fixing anything that is so-called problematic, pathologized, or seen as a medical issue. Expanding on that a little bit further, we know, of course, that the medical model has this really intense emphasis on finding cures and using medical technology or other treatments to cure or get rid of illnesses and disabilities. We have these messages all over the place in our society that it's always better not to be disabled, that a non-disabled life is always going to be a higher quality of life. And that is absolutely just not true. That is way too simple of a perspective. It does not look at the nuance of disability or the reality of chronic illness, which is that it really depends on a lot of different things. There's a lot of gray area here, and every person, disabled or non-disabled, is going to have a very different life and very different experiences. Of course, there are some cures that are very beneficial. There's a lot of medical technology that is amazing and so helpful. And we are not, here to dismiss that. We're not here to diminish the importance of those cures, the importance of those treatments. There are some things that are absolutely amazing that have been developed, especially in the last handful of decades. However, not everything can be cured, and we really do have this obsession with finding a cure for everything in our society, but some conditions can't be cured. There are a lot of medical conditions or disabilities that are simply just a fact. They're just going to be there. They're not going anywhere. A lot of different kinds of neurodivergence and mental health conditions or statuses are things that cannot be cured, things that will not go away. One great example is autism. There is the hate group out there, Autism Speaks, that is seeking a cure for autism when rather autism is just a neurotype. It's just a different way of being a person. Um, and that is something that is likely never going to be cured. And a lot of people would argue we should not be looking for a cure for something that is just a way of existing as a person. It's just a different kind of human experience. Also, there are a lot of people who don't want to be cured. A lot of people with disabilities don't want to get better, don't want to change, don't want to go through medical intervention to alter their body or their experiences. There are a lot of reasons why a person might enjoy being disabled. Maybe they are just very comfortable with that. They're very familiar with that, and they're like, hey, this is just how my reality is. This is the body that I have, and that's cool. Um, Other people might have different reasons to want to stay disabled, or they just don't want to go through that process of finding a cure, going through treatments, going through surgeries, whatever that might look like for that person. I would encourage you to think more about this. Why do we have this obsession or this drive to get rid of illnesses and disabilities? Why do we have so few people embracing these kinds of things and these identities? And why do the people who do embrace those things not want to be cured? What is that experience like? What is that reality like? And what are some examples of these kinds of perspectives happening in our society? Switching gears now to discuss a little bit more of a difficult topic here. Not that we've been discussing very light topics so far through this lecture, but life support technology, we are going to be dealing a little bit with the topic of death in these next following slides. If that's something that is difficult for you to hear about right now, or for you to learn about at this moment, feel free to skip this last part of the lecture. I would encourage you still to do the readings for this week. They are very interesting, and some of this information is going to be important to our assignments in the class. Um, but I know that this is a very difficult topic. So life support technology, what is it? This can include things like respirators and feeding tubes and other types of technology used to sustain a person's physical body when their body is not in a state to sustain itself. There are, of course, a lot of benefits to life support technology. There are also a lot of cons to this technology as well. This is one of our great examples of a medical technology that introduces a lot of dilemmas. Diving into some of the dilemmas or the ethical considerations of life support technologies, of course, this technology makes it kind of complicated to define what is life, what is death. We kind of have this gray area for a person who is on life support technology whose body is not able to sustain itself, but perhaps that technology keeps that person breathing, keeps their heart beating, and they can look rather lifelike in a lot of ways. Um, so we've actually had to expand and change our definitions of death as this technology has developed. We also have pretty limited research on the effectiveness of life support technology. It's really difficult to do research without a control group, but we absolutely cannot ethically, as medical practitioners, assign people to a control group if we think that might be negative for their health outcomes. So in this case, say we have two people with very, very similar medical emergencies, and we only put one person on life support and not the other. If we think that that life support could potentially save either life, it is very unethical not to use that technology or to withhold that treatment from either person. And so it's kind of tricky in this case. We mostly are researching people who were put on life support in no comparison to people who were not. And so we don't have a control group or an experimental group. We are only looking at people who are on life support and the outcomes of that group. Unfortunately, we actually don't even see very good outcomes for people who are on life support. Individuals tend not to recover when they are on life support. It's very, very rare and very unlikely in most cases. So the use of life support technology, we know, can sustain a version of life or something that resembles life, but the chance of someone recovering and being able to live independently is pretty low. Life support technology, this also requires a lot of resources. It's a lot of technology, a lot of time, and a lot of medical practitioners engaging with that patient, making sure that that person is in good shape. And it really is a big investment in resources. And so we kind of need to think about, is it worth it? Not in every case, right? Some people would not necessarily want to be on life support. There are a lot of reasons why a person might feel very strongly against being on life support. And so if that family knows about that person's wishes, that's really good. But sometimes we don't always have that information. So these kinds of decisions that doctors or families are making, we're looking at things like resources, quality of life, chance of recovery, and when should we remove that life support technology? When should we withdraw from providing that kind of support to that person? Um, it's a very, very difficult decision to make. Um, some of the things that can make that decision a little bit easier or at least a little more straightforward, if a person has something called a living will, or sometimes we also call this an advance directive, that person might have a power of attorney, whether it's their spouse, loved one, parent, sibling, whoever it might be, who gets to kind of act out what that person says that they wanted in that document. A person might say, I'm okay with being on life support for 2 weeks or 2 months or 2 years, but after that point, then please stop the use of that technology. This can also be a family decision. This is going to always be made with the input of the physicians on site. Um, the doctors are going to be able to give recommendations about what to do, what not to do, and timing in this kind of situation. If a person does not have a will or a living will or advance directive, kind of giving some direction for that case. We also, of course, when we're looking at life support technology, have some debates about organ donation. A lot of people who are on life support are really good candidates for organ donation, particularly if those individuals have fairly healthy bodies and potentially just um, have brain death or a case where the brain stem is no longer active, but the organs are fairly functioning. But a lot of people think this is really problematic, right? Are we keeping people on life support as kind of like an incubation period before we harvest their organs? And of course, in the case of organ donation, organs will not be taken from someone who did not opt in to being an organ donor or whose family does not make that decision for them in a context where those ethics and that morality is all, very well guided and discussed. And so, if you're at all concerned about life support being used to harvest organs or sustain people as organ farms, um, the concern is very real, it's well founded, but that is not something that we see evidence of at this point in time. Organ donation from people who are on life support is going to be done with the consent of that person or their family in a very organized and constructed and heavily discussed way. It's not going to be some kind of last minute decision either. Finally, I think it's really interesting to discuss the debate about different kinds of removal of life support or medical technology or treatment. Often it's seen as more ethical to remove this artificial life support or to pull the plug, so to speak, than to end the functioning of an independently functioning body. Um, if you all are familiar with the concept of physician-assisted death, there are medications that an individual can take under certain contexts and in certain places that can cause the death of their physical body. And so we see this ethical debate about, pulling the plug being more ethical than taking pills that end the life of a person who can function without a respirator, without a feeding tube, without all of those machines. And I don't have an answer for you here. I think it's just interesting to explore. Is one more ethical than the other? Is one more moral than the other? What factor is played by the fact that a person on life support is probably unaware of what's happening versus a person engaging in physician-assisted death being very aware? That's actually a requirement of that kind of practice. So often a lot of doctors are more comfortable with ceasing life support than prescribing those medications for physician-assisted death. And it's very interesting to see how this removal of artificial life from a body that doesn't function independently, how that's seen as maybe less real of a death, or less like ending a person's death rather than ending a person's life or causing their death in comparison to those medications. So it's very interesting to look at that contrast there. All right, just because we've been on this topic for a while here, I think it's important that we discuss how this affects us all in our very real day-to-day realities. And so it's never a bad idea to kind of be thinking about these things, as difficult as they are, for yourself and for your loved ones. Having these conversations is really important. So every single person can have a living will. You can write an advance directive. You may even have been asked about this at doctor's appointments, regardless of your age, but especially as you get into your 20s and later. If you're even older than that as well, there's a lot of different offices that will start to ask those questions. I believe when you hit about 25 is when those questions start to pop up more often on medical paperwork or screening portals. So it's important to think about, if you are in a situation where you might need to be put on life support to survive, do you want to be put on life support? And if yes, for how long? What kind of boundaries or stipulations do you want to set for that kind of thing? Who might be in charge of making medical decisions for you? Who would be that power of attorney? Would it be a parent, a loved one, a spouse, a significant other, sibling, your boss, whoever is the person that could make those medical decisions for you if you're not able to make those decisions. And then finally, if you have any ideas about this, it's good to kind of at least be thinking about it if you don't have a definitive plan yet. But what do you think you might want to have done with your body after you are no longer alive? Do you want to be cremated? Do you want to be buried? Do you want to explore other kinds of options? There are a lot of different kinds of green burials. There are a lot of really cool technologies coming out. In a way, I guess we could consider them medical technologies in the last handful of years. Things like aquamation, or also known as water cremation, human composting. You can donate your body to a body farm for forensic science. There are a lot of options. And so that's something that's definitely worth thinking about. As difficult as it is, these are things that can go a really long way in this kind of situation because at some point or another, every single person will die. Sorry to break it to you, but that is a part of human reality. And so taking those steps, writing that advance directive, writing that will, that can make things much, much easier if someone does have to make those decisions for you, or if you do pass away and someone is making a plan for your funeral or some kind of memorial service. In a moment of grieving, having to make decisions without that knowledge is really difficult. And so if it's all, lined up, it's written out on paper and they can just follow those instructions that you left, that can make things a lot easier for the people that are left behind. So, in summary, medical technology, of course, is amazing in so many ways. There are so many advancements that have just really made human quality of life so much better, have saved so many lives, and there is absolutely just no overstating how amazing medical technology is for our current state as humanity. But of course, there are a lot of cons to medical technology. There are a lot of dilemmas. There are a lot of moral and ethical issues and things that are being constantly debated throughout our society. We're going to continue to have more advancements, so we're never going to stop having these conversations. But a few other things that we could have explored this week would be listed here: gene editing technology, genetic counseling, chemotherapy and other cancer treatments, physician-assisted death, cosmetic surgeries, especially weight loss surgeries, and also data privacy concerns as we move into a more software-focused way of keeping track of data and medical information. There are, of course, privacy concerns and data breaches and things like that to be worried about. So there are just countless examples of medical technology, countless examples of both benefits and potential dilemmas related to this technology. But this week we just kind of got into a little overview of some of the different technologies that I think are particularly interesting. I'm sure you all have a lot of ideas as well about these kinds of things, but thank you for being here this week, and I look forward to seeing you next week.